So what about this particular patient then? We've got a 58-year-old man, 4-month history of weight loss, drenching night sweat, myalgia, severe occipital headache. And when you examine the patient, there's skull pain, there's left-sided temporal tenderness, there's strong peripheral pulses, the blood pressure is hypertensive, is slightly anemic, CK, creatine kinase, is slightly high, ESR is high, plus. So what is going to be the diagnosis? And more importantly, the question is asking you what's the most appropriate investigation for this particular individual. So what do you think is the answer? Have a think. Okay, is it A, anchor, B, echocardiogram, C, the CT, D, CT, PET CT, or E, muscle biopsy? What do you do? Which is the proper investigation for this gentleman who's got systemic symptoms, which includes weight loss, night sweat, myalgia, headaches, and also scalp pain, temporal tenderness, etc., with deranged blood test results? Which one would you go for? Give you a couple more seconds to have a think about before we reveal the answer. The answer is D, CT PET scan. So why? So let's have a think. Okay, let's have a think what this condition has. So this patient's symptom has weight loss, night sweat, constitutional symptoms basically, myalgia. They also got severe occipital headaches, and that suggests to me that this is suggestive overall of a systemic inflammatory process. Okay, now the examiner give you some further information here. And remember what the examiner does. The examiner never tries to trick you, really. There's never going to give you some red herring in the majority of cases. So the information that they give you is going to be important. In this particular case, we've got scalp hyperesthesia and temporal tenderness, okay? And that further points towards a diagnosis of giant cell arteritis, okay? That's also known as temporal arteritis too. So that's GCA. That points towards GCA, given the scalp tenderness, given the temporal tenderness as well. It's the age group. It fits. It's very common in the over 50s. This particular chap is at 58 as well. And GCA also causes elevated inflammatory ESR and CRP results as well too. And obviously, we may want to go for a temporal artery biopsy or ultrasound depending on the guidelines that you want to follow. Okay. And obviously with GCA, you need to go through. Now, what about this then? Okay, so if you're going to go for, if we think this is GCA, so why do we choose D? Okay, let's go through each one in turn. Why isn't it anchor? Well, anchor, if you were thinking about things like small vessel vasculitides, so granulomatoses with polyangiitis, GPA, or microscopic polyangiitis, MPA. But with this patient's presentation, with this scalp pain and temporal tenderness, that tells me is GCA, giant cell arteritis. This is a large vessel vasculitides. So anchor would not be appropriate at this stage. Anchor is used for small vessel vasculitic disorders. What about echocardiogram? If you thought that this could be due to something like infective endocarditis, causing anemia, drenching night sweat, weight loss, constitutional symptoms, you might be right. Okay, you might be right. But because of the systemic inflammatory response, however, it wouldn't explain anything else in this particular case. It wouldn't explain the findings in the scalp, for example. What about CT PET scan? What about a CT chest after pelvis? Now that's relatively common. If you thought this was something like a solid tumor, if this was like a tumor or this was something like a lymphoma, you were that this got metastasis somewhere, that could be a relatively reasonable suggestion to take if you're thinking about constitutional B symptoms that this patient has. But for someone like this, it wouldn't explain the scalp tenderness, and it really wouldn't explain neatly about the rest of the symptoms that this patient presents with. Okay, so while CT chest after pelvis may be a good useful step if this is very more generic, the fact that we've got scalp tenderness, temporal tenderness as well, that points toward GCA, in which case would you not do a CT chest after pelvis, because it wouldn't tell us about the vessels and what's been happening there. The difference is CT PET scan. Because a CT PET scan is useful, because it will tell us about large vessel inflammation. Okay, it'll tell me about large vessel inflammation in the arteries, such as the aorta and the branches of the aorta, and also it can help establish the extent of the disease and guide how we're going to treat it. Okay, now the second thing apart from that is the temporal artery biopsy or ultrasound can also be considered as a firm diagnosis of this. Now, some of you will say, oh, CK is high, quick, let's jump to that. Now, that's useful if there's something like a myopathy to investigate the cause of a myalgia, obviously. But, however, this is more to do with large artery issues rather than a primary muscle disorder. Okay, so So that's not going to be the particular case, and it's not going to be as useful for us here, whereas GCA is what this points to. Now, the diagnosis of GCA, giant cell arteritis, is almost always clinical. Okay, 75% of patients will have a headache. Normally, a very dull headache in the temporal region, but it can be occipital, can be parietal, and it carries on insidiously. It means it just carries on gradually. It's not like a thunderclap headache. It progresses through time. Sometimes people get visual symptoms as well. Okay, the reason why it's so important, the reason why you need to examine the eyes, for example, is the fact that obviously it affects the central retinal arteries. Then it can cause partial or complete loss of vision, or even diplopia for some cases. Now, obviously, scalp tenderness is useful to note, and jaw or tongue claudication is important, and that happens around a third of the cases, because when the tongue is chewing, and you get this claudication symptom, this pain in the jaw, pain in the tongue, that's due to ischemia in the masseter muscles. So almost always you're going to get systemic symptoms, really. And sometimes that can involve things like PMR symptoms as well, polymyalgia rheumatica, which may coexist. By that I mean you got proximal muscle pains, early morning stiffness, so such as the myalgia that we see in this last vignette that we had here. Okay. Now, what you're going to do, you're obviously going to palpate for the temporal arteries on the side of the head. You're going to palpate for hard lumps and the lack of pulsation. They're like knots, basically. And you may want to do a full vascular examination to look for carotid bruit, differential blood pressure in both arms, because that might tell you of the infiltration of the large vessel vasculitides as well. And take a look at the eyes as well. Acuity, fundoscopy, look for any signs of visual disturbance too. And whilst you're doing that, make sure that you take some ESR and CRP, because the vast majority of patients with GCA will have elevated inflammatory markers, even though they're not very specific. And if you do suspect GCA, please start prednisolone, start steroid early, even when you refer the patient on the same day. The reason being, and you shouldn't be waiting for outpatient review before starting prednisolone steroid, the reason being is that it can cause catastrophic disability in the form of blindness. So that's why you should start it. And you should consider things like PPI, omeprazole, cover, etc. Now, sometimes in the old school days, you might have started or read about in textbooks that you might start aspirin alongside this, but it's not the case today. So you do not start aspirin. You just start prednisolone and you start a PPI cover if it's relevant. And obviously onward referral for rheumatology for them to monitor and the disease progression. And I just wanted to show you here in this particular photo, this is a gentleman on the left-hand side where we can see a knotty appearance, almost like ropes, and there's knots on the ropes as well of a temporal artery, which isn't very pulsatile at all, but is tender when you touch it. This is the keeping with GCA, giant cell arteritis, or temporal arteritis, based on the anatomical location.